I think I'm going to start. Welcome to Grand Rounds, and welcome to those people that are present in the auditorium. I'm sure there will be more, and apologize for not being there. Before I introduce our speaker today, I just want to make a land acknowledgement. I'd like to acknowledge that we are gathered on the traditional and ancestral and unceded territory of the Coast Salish people. We're very grateful for the stewardship of this land. Today's Grand Round is, as you can see, the rising tide in chronic lymphocytic leukemia novel therapies. Dr. Ramadan, one of the hematologists at St. Paul's, is going to present this. And it's always a privilege to learn about our colleagues and their training. So Dr. Ramadan trained in Ireland. And then without going into the dates, trained as well in the UK with his hematology training and his Royal College of Pathologists training in the UK, and then came to Vancouver and worked in the bone marrow in research fellowship in lymphoma, leukemia, and bone marrow transplant from 2005 to 2006, and has been a member of the St. Paul's Hematology Department since 2007. He's got an interest in chronic lymphocytic leukemia and is going to present the topic today. Dr. Ramadan.
Thank you so much, Perry. I'm here to present the changes that we have witnessed over the past 10 years in the treatments and treatment regimens that we use to treat our patients with CLL. Just going to figure out how to change the slides here. Yep. So these are my disclosures here. I being paid for as an advisor consultant for these pharmaceutical companies, AstraZeneca, AbbVie, Roche, Celgene, Janssen, and Sanofi, and received research grants from Roche, Celgene, and Janssen. And the objectives of this talk today is to discuss, of course, the advances in treating patients with CLL. There is a remarkable and radical shift from what we used to use with the treating our patients with chemoimmunotherapy to targeted therapy, and that has happened over the past 10 years or so. So the landscape has totally changed in the way that we treat CLL patients these days. We also have developed some very good predictive markers that guide us how we treat our patients and use more personalized medicine. And also, I'm going to hint into the gap between the evidence-based medicine, what we should use, and what we have an access to. The access, of course, to medications can be limited. It can be delayed based on the funding of these medications and based if we have a compassionate access program provided by pharmaceutical companies. This is a historical overview of how the prognostic markers as well as the clinical advancements in treating CLL. And as you can see, this started back in 1950s. In 1958, there was a publication about the use of chlorambucil, which was used for so many years and decades treating CLL patients. And that has changed. And you can see that the time frame is shrinking as the new therapies came around. Chlorambucil basically dedicated the landscape or dedicated the treatment algorithms for so many years and decades until in the late 1990s, early 2000s, where the fludarabine, the purine analogs became available. And at that point, of course, people started experimenting with newer treatments and combinations. Fludarabine was a promising agent to have, and eventually not quite sure, there's lots of noise.
Could people mute?
Can everyone please mute so we can talk here? If you are not talking or not asking questions, please mute. So that has evolved with some combination treatments with the fludarabine and cyclophosphamide in the late 1990s, early 2000s, to then later on adding the monoclonal antibodies, rituximab, and eventually the immunochemotherapy with fludarabine-based therapy and rituximab became the standard of care with either fludarabine and rituximab or fludarabine, cyclophosphamide, and rituximab. That, of course, has changed in the past 10 years with newer targeted treatments and that they target the BCR, B cell receptor pathway. The most notable one would be the PTK inhibitor, the proton kinase inhibitors, with the ibrutinib was the first that came and became available. And then we also have some other inhibitors here, the PI3 kinase inhibitor, and lately in the after around 2015 2016 the BCL2 antagonists or inhibitors became available. The venetoclax is the one that we use nowadays. More notably, of course, the CAR-T came into play in many like leukemia fields and in lymphoproliferative diseases. Diffuse large B-cell lymphoma is probably it's well developed now and funded treatment. But for the CLL, it's still under study. So the CAR-T is also one of the promising therapies for patients with CLL. So this is the legacy story. I stood here 10 years ago, presented the treatment algorithm for CLL patients, and that's what I presented back then. Patients diagnosed with CLL, they go over a period of observation. We call it observation. We call it watchful waiting. Some people just call it, go home and relax. Don't worry about it. But whatever it is a period of time that ends up with a long-term observation or monitoring for about 67 to 70% of patients who would never require a treatment for this disease. Having said that, this is a period of time that we usually use to educate our patients, inform them about their diagnosis, how to reduce the complications or the risk of complications of CLL. Infectious complications would be probably the most notable one. Give them advice regarding vaccinations and how the vaccinations are important to reduce the risk of infectious complications. However, about 30 to 40% of patients will eventually meet the IWCLL criteria for treatment, and they need treatment for their CLL. Those patients either have a bone marrow failure with anemia, thrombocytopenia, or they develop a progressive lymphadenopathies or constitutional symptoms. Either way, they would meet the criteria for treatment and they require treatment for their CLL. The way that we use to stratify those patients, it's basically based on their clinical markers here or factors. We had some prognostic markers back then. FISH was, I guess, is the one that we've used for a long time. 17p deletion was the very poor prognostic marker there that we tend to, if the patient is transplant eligible, because they don't really respond well to the chemotherapy or immunochemotherapy, so they end up having bone marrow transplant allogeneic if they are fit for this procedure. And the IGHV mutation status was not available until recently. ZAP70 was used, it's a flow test that is used as a surrogate marker for the IGHV mutation status. CD38 is also a marker that we used. But in any case, those patients were stratified based on their age and comorbidities and fitness. So the ones who are less than 65 fit and no comorbidities, they will go for intensive chemotherapy regimen such as FCR or FR. And the ones who are above 65 years of age and fit have some comorbidities with the cumulative illness rating score above 6. They will go with milder chemotherapy such as bendamustine and rituximab or fludarabine and rituximab. The ones who are unfit and elderly or frail, they go on the chlorambucil and rituximab or obinutuzumab. Eventually, patients relapse, and what we do at that point, we either recycle another chemotherapy regimen, or if the patient is fit for transplant, we ask for transplant opinion, or they go on palliative treatment. So that was the picture back then. And for those who attended that lecture, is basically, it's going to be totally different today. The landscape has totally changed and radically changed. And for the ones who did not attend it, you don't really need to remember anything of this slide, because it is not really not how we treat our patients nowadays. If you look at the guidelines on how to treat patients with as a front line treatment or treatment naive CLL patients, and you look at the NCCN guidelines, the striking thing about these guidelines is they don't even mention the chemoimmunotherapy anymore. And there's no mention of fludarabine, there's no mention of cyclophosphamide, there's no mention of any of these chemotherapy agents that we used to use. It's all targeted treatment nowadays. It doesn't mean that we don't use the chemoimmunotherapy anymore. We still use it in a select group of patients, mostly because of the access restrictions, and we are not able to get the targeted therapy for them. But the point is, those targeted treatments are very effective. The BTK inhibitors, ibrutinib, acalabrutinib, are very effective treatments. The venetoclax, the BCL2 inhibitor, is also very effective treatment. So whether the patients are frail with significant comorbidities, older patients or younger patients, those treatments are really very effective and provide a long-term progression-free survival. Patients below age of 65 without significant comorbidities, these are basically the ones that we are still struggling with, at least here in BC, because the access to the targeted treatments and novel therapies is restricted. Patients with mutated TP53 or deletion 17p, they respond poorly to chemoimmunotherapy. So the targeted therapy would be the recommended treatments. The same thing for the guidelines from in Europe by ISMO. They still have the chemoimmunotherapy on the picture here, but mostly the category 1 advice or recommendation would be the targeted therapy. So what we do here in BC, it is pretty much in line with the recommendations and the guidelines. Having said that, there is a group of patients where we still don't have the access for the targeted therapy. Patients, again, they go through the period of observation, and the ones who need treatment then are stratified now based on some predictive markers. So we changed in terms of using these markers as prognostic markers, now to use them as predictive markers, which is really a huge step forward in terms of personalized medicine and how we treat the right patients with the right treatment at the right time. If patients have deletion 17p or unmutated IGHV, which is this test is also available, and the credit goes to my colleagues, Dr. Sidney Toes at VGH and Elena Gary at the BC Cancer Agency, who pushed hard to have this test available. And it is a really important test to have because, patients who have unmutated IGHV gene, they have worse prognosis and they do poorly on chemoimmunotherapy. So the recommendation nowadays is for those patients is to receive novel therapies. The most probably recommended one would be continuous treatment with proton tyrosine kinase inhibitors such as ibrutinib or acalabrutinib or zanubrutinib, which has still been studied in CLL. If patients don't have these mutations, no 17p deletion, and they have a mutated IGHV gene, it depends. If they are fit, less than 65 years of age, and have no comorbidities, the treatment would be FCR. Unfortunately, for this group of patients, we don't have funding for any of the targeted therapies, we still use the chemoimmunotherapy. The reason for that is the FCR actually has provided very good efficacy for those patients. And those patients usually go on with so many years of remission. And there's also a potential for cure. I have few patients who are treated with FCR many years ago, over 10 years ago, and they're still doing well. So the ones who don't have any mutated, in other words, they have a mutated gene, they don't have 17p deletion, they don't have any of the unfavorable markers for CLL, they do well on FCR. Having said that, this is a toxic regimen. It can result into prolonged cytopenias. Some of the cytopenias are long-lived. And of course, it increases the morbidities or can become a barrier, for some things like surgeries, etc. And also the other issue, of course, with the FCR, although it's a fixed duration treatment, 8 cycles, and patients, are done with the treatment, it does increase the risk of myeloid malignancies, notably acute myeloid leukemia. That happens in about 5 to 10% of cases, and it has extremely poor prognosis. So this is a concern with the FCR. I really think, we need to continue working to get the novel therapies and targeted therapies available for those patients. For the ones who are not FCR eligible, in other words, above age of 65, or have comorbidities, or they have some complications of the disease that make the fludarabine not a safe medication to administer, such as autoimmune hemolytic anemia or ITP, those patients are eligible for targeted therapy. Apretinib has been available for a period of time now for those patients. Acalabrutinib just been funded by the Cancer Agency in February this year. Venetoclax and obinutuzumab is also being funded this year as a frontline therapy for patients who are FCR ineligible. Venetoclax and obinutuzumab provide the advantage of it as a fixed duration therapy. So it's only for 1 year. So it is a good argument to have. And it's also, I guess, it saves quite a bit of money. And those medications, by the way, are extremely expensive. Apretinib, 1 year treatment with apretinib costs around $100,000. Venetoclax, 1 year of treatment, it costs around $150,000. So they are really extremely expensive medications. So fixed duration treatment with venetoclax and obinutuzumab, which is a monoclonal antibody, can provide a good deep response and a prolonged disease control and very durable response. Once patients relapse on any one of these medications or treatments, they can go on the other one that they have not experienced. If they, of course, progressed on PTKI inhibitors such as apretinib or acalabrutinib, they can go on venetoclax or venetoclax and rituximab. If they relapsed on venetoclax, then they can go on the PTKI inhibitor. Idelalisib, which is a PI3 kinase inhibitor with the rituximab, is a different combination, and it's a different treatment. It is toxic. It can cause some life-threatening complications such as colitis, pneumonia, severe infections, serious infections. So it's basically reserved, for patients who need to be debulked and they are deemed eligible for bone marrow transplant. So how the B cell receptor pathway works and where the BTK fits. Here is the BCR receptor. With the antigen stimulation, there is a downstream activation of various enzymes. Here is the BTK, and that's where the apretinib, acalabrutinib, and zanubrutinib inhibit, and basically they disrupt this activation, and it results into deprivation of the cells of many markers that are important for their survival, proliferation, adhesion, and differentiation. CLL cells are very vulnerable cells. They need lots of adhesion and interaction with what we call it nursing cells or the microenvironment. And once that microenvironment and the adhesions are disrupted, and the CLL cells die. They don't survive. The ibrutinib being the first BTKI that was approved, it is approved for many indications these days, but for CLL, it's basically across the board from frontline therapy to relapsed disease. It's potent, but it inhibits many other enzymes, so it is off target. There are newer BTKI inhibitors, such as acalabrutinib and zanubrutinib, that are more specific. And being more specific, it means it has less side effects. So the ibrutinib, I guess, lots of side effects that we see, from arthralgia to diarrhea to skin rash, it results from the inhibition of the EGFR and the bleeding and the cardiac toxicity, such as the atrial fibrillation and in some cases ventricular arrhythmias. They happen from the off-target kinase inhibition of the TEC. The acalabrutinib and zanubrutinib have less off-target inhibition, and therefore they are safer with less side effects. So it's good to have these medications. I mean, not the zanubrutinib. Zanubrutinib is not being approved for the use in CLL. The studies are still undergoing, but it's been approved by Health Canada for the use in relapsed refractory mantle cell lymphoma and Waldenstrom's macroglobulinemia. Acalabrutinib is. So we have acalabrutinib that is approved by Health Canada, and it is funded by the Cancer Agency as of February this year. So this is basically the same thing as I spoke about the ibrutinib, acalabrutinib, the zanubrutinib. This is first generation ibrutinib. Second generation acalabrutinib and zanubrutinib. We have all of them except the zanubrutinib approved in CLL. And there is a newer PTKI inhibitors. You know, the ibrutinib, acalabrutinib, and zanubrutinib, they are covalent irreversible inhibition of the BTK enzymes. Pirtobrutinib is different. It is reversible, non-covalent, and it has less side effects compared to ibrutinib. But also it has the advantage that it overcomes the resistance to ibrutinib. There is a mutation that happens, it's called C48 mutation, that renders the ibrutinib ineffective. And it happens after years of use, treating patients with the ibrutinib. Pirtobrutinib, having this new medication that is still under study, would overcome that mutation that is the most common that result into resistance to ibrutinib. So this is very promising agent. We're looking forward, to the phase 3 study that it's currently being conducted, and we're looking forward, to see this medication, further developed and being available to our patients who become resistant to ibrutinib or acalabrutinib. Acalabrutinib and zanubrutinib, they don't overcome the resistance. They have better side effects profile compared to ibrutinib, but they don't overcome the resistance to ibrutinib. What is the real world? I mean, we can talk a lot about the clinical studies, and there's tons of them that we can discuss. But the real world actually says that the side effects to PTKIs is the major barrier to continue treatment. With the US experience is not really different from the European experience, about the discontinuation rate of 40%. Some of it, of course, is due to resistance, but lots of it is due to side effects. My experience, about over 1/3 of patients will come off the ibrutinib because of the side effects, because of intolerance issues. These side effects are the greatest in the first 6 months. So if you can take the patients through the first 6 months and support them, it's likely that they're going to stay on the medication and benefit from it. Of course, if you discontinue the medication early, patients would require treatment. If the patients, stay on the medication for a longer period of time, I have few cases who discontinued the treatment after 2 years plus, and those patients stayed in remission. So the longer that they stay on the treatment, the more likely that they will stay in remission after they discontinue the treatment, if it is because of intolerance. We have a long list of active medications in CLL and chemotherapy. We talked about chlorambucil being the first that has been developed back in 1950s, cyclophosphamide, fludarabine combinations, CVP, CHOP chemotherapy. And we have the immunotherapy, the monoclonal antibodies that are active against CD20, rituximab. Alemtuzumab is anti-CD52. Ofatumumab, anti-CD20. Obinutuzumab is anti-CD20. And they have slightly different mechanisms of action, the anti-CD20s, with different efficacy and side effects profile. Obinutuzumab is known to cause more infusion-related side effects compared to rituximab. But these are the immunotherapies that we combined with chemotherapy and treated CLL patients for a long period of time, about maybe from mid 2000s until 2015. They were the mainstay of treatment for CLL. Targeted therapy, we have the BTKI, we have the covalent irreversible PTKI inhibitors, iprotinib, acalabrutinib, and zanubrutinib, which has not yet been approved for the use in CLL, but in other lymphoproliferative disorders. And we have the true second generation, that is the non-covalent reversible inhibition of the BTK enzymes, which is the pirtobrutinib. We have the other targeted therapy, the PI3 kinase inhibitors, the idelalisib and duvelisib. And we have the one that we are using nowadays, and it's funded and it's very effective treatment for CLL. It's the BCL2 inhibitor, the venetoclax. I just wanted to make the case for the personalized medicine here and how we use the genetic data to make our decisions on how we treat patients with CLL, treatment-naive patients. And these are the clinical studies that we have at our disposal to look at for first-line treatment. We have the ECOG study that compared the FCR with ibrutinib and rituximab, then followed by ibrutinib maintenance. This was for the fit patients, the younger patients. We have the Alliance study, which is basically included the 17p deletion patients and compared the bendamustine and rituximab versus the ibrutinib and rituximab versus the ibrutinib. You need to go back. Versus the ibrutinib. And the Alliance study actually is a very important study. It's the study that it showed basically there is no difference between the ibrutinib monotherapy versus the ibrutinib and the rituximab. Basically, the curves are overlapping, and this is the first, perhaps, trial that it showed in the lymphoproliferative context, and treating the lymphoproliferative disorders, that adding the monoclonal antibody CD20 is not adding any benefit, which is really important to know. It's important to realize that, the notion of adding the monoclonal antibodies doesn't always result into an improvement in the efficacy. Illuminate is another study that is basically for unfit patients that compared the obinutuzumab, ibrutinib versus chlorambucil and ibrutinib. Elevate for the treatment naive, it compared the acalabrutinib. It was for the unfit patients, compared the acalabrutinib with the obinutuzumab versus acalabrutinib versus chlorambucil and obinutuzumab. We have the Sequoia study, which is ongoing. It's for the zanubrutinib versus PR for the older patients. And we have the CLL14 study that is for the unfit patients. So we have a quite few randomized clinical studies at our disposal. Many of them actually have included the 17p deletion and the poor prognostic markers, the bad actors, which has basically, helped us to understand where to or how we treat those patients, either with chemoimmunotherapy, which is, I don't think it is a good option for those patients anymore, or with the targeted therapy. The zanubrutinib versus PR, you can see the curve here It's for the more the elderly patients, and the benefit with the zanubrutinib was observed across the subgroups, including the bad actors. Having said that, the 17p deletion patients have been excluded from this study. But certainly, it was very clear that patients with the unmutated have benefited from the zanubrutinib compared to the chemoimmunotherapy. And the unmutated is basically the ones who have a poor prognosis compared to the mutated group. There's a consistent benefit in the unmutated with the BTKI, with the Resonate study, with the Illuminate study, and with the Alliance. You can see all the curves here widely separated, which makes the argument nowadays, if you have a patient with CLL that you would need a treatment, you will need to test for the IGHV mutation status. And if those patients are unmutated, you should provide or offer them targeted therapy, which is funded and available. For the TB53, we have the Alliance, we have the Illuminate, and we have the Elevate treatment-naive patients. And across the board, it showed the benefit of the targeted therapy compared to chemotherapy. So it's also a question that has been settled now. So these two groups of patients with the unmutated and the 17p deletion or TB53 mutation, they should be offered targeted therapy. We have the fixed duration venetoclax and the obinutuzumab. As I told you, this is an important treatment regimen because it is basically, you don't really, lots of people actually get concerned about the continuous treatment, treatment for years and years on a medication, which is, I guess, it's a valid concern. And also, the expense of using continuous therapy is very evident, when your treatment regimen costs around $100,000 per year. So the fixed duration treatment became very attractive option here. And with venetoclax and obinutuzumab, you can achieve a very deep response, high rates of negativity, MRD negativity, and basically saves quite a bit of money. And those patients who treated with the venetoclax and obinutuzumab with or without TB53 mutations have a better outcome compared to the ones who are treated with the chlorambucil and obinutuzumab. Having said that, the fixed duration treatment using venetoclax and obinutuzumab for the TB53 mutation in particular was deemed probably not as effective as the continuous treatment with the BTKI. So lots of people nowadays for the 17p deletion patients or the TB53 mutated patients, the continuous treatment with the BTKI would be the standard of care. The analysis of the subgroups with the venetoclax is basically in favor of venetoclax and obinutuzumab compared to chlorambucil. So in summary, we have achieved quite very important, milestones in terms of how we treat patients with CLL and use personalized medicine. In this case, basically we use the genetic markers. So patients with unmutated immunoglobulin heavy chain should be offered targeted therapy with either continuous BTKI or fixed duration BCL2 inhibitor, either ibrutinib, acalabrutinib for the BTKI or the venetoclax for the BCL2 inhibitor. Choice of treatment regimen depends on the clinical factors and potential side effects profile, which it varies between the BTKI and the BCL2 inhibitors. Both of them are good options, valid options, provide very durable responses for patients with unmutated IGHV. For patients with the 17p deletion and the continuous treatment with the BTKI, is probably a better option at the moment. We're still waiting for the data on the fixed duration BCL2 inhibitor, the venetoclax. But until we have that data, continuous treatment with the BTKI for the 17B deletion patients would be the appropriate choice. 17B deletion doesn't happen in a huge percentage of patients. It only happens in 10%. So it's not really, you're not talking about a significant or large number of patients. At the moment, continuous treatment with the BTKI would be the appropriate treatment. So let us talk about the favorable risk CLL. So we talked about the unfavorable ones with the 17B deletion or any mutated gene. What about the ones with favorable risk? I want to go one step back and explain a little bit about the immunoglobulin heavy chain. Immunoglobulin heavy chain, it's basically, we always think about a mutation as a bad thing, and the ones who have no mutation is a good thing. It is counterintuitive. For CLL, the ones with the N-mutated have the poor prognosis. The ones with the mutated have a better prognosis. What happens is, of course, with our immunoglobulin heavy chain gene, it gets hypermutated when it's exposed to or involved in an immune response. So when there is an antigenic response or stimulation, the immunoglobulin heavy chain will go over hypermutation, and then that cell will be able to produce a specific immunoglobulin that is targeting an antigen, virus, bacteria, whatever it is. The unmutated ones are the ones who have not been stimulated yet. So they are still at early stages of development, or they have not been developed. They have not gone through the germinal center, and they have not been exposed to the antigenic stimulation. So the unmutated ones are the ones are more or less mature, from what we know from the data is patients with the unmutated have they progress faster to treatment, about 2 to 4 years from the diagnosis of CLL until they require treatment, compared to 5 to 7 years for the patients with the mutated IGHV gene. Survival, once they require treatment, of course, it's very evident that, patients with the mutated, they fare better than the ones with the unmutated. Again, going and understanding, how the B cells develop, and they go through the germinal center with the antigenic stimulation and the hypermutation, and they change from unmutated to mutated. This is how, the cells become more mature. The fludarabine, cyclophosphamide, and rituximab, the FCR regimen, which was approved after the big German study, the CLL8 study that was done back in the mid-2000s, it showed that patients with the immutated and lower beta-2 microglobulin, they do really well. 60%, over 60% long time or long survival, very durable remission. The ones with the mutated and a higher beta-2 microglobulin, they do less well. But certainly the ones with the unmutated IGHV gene, they do poorly. So those are the ones that we don't really treat with the FCR anymore or any chemoimmunotherapy. We treat with targeted therapy. With targeted therapy, you overcome this bad prognostic marker, and these curves actually go up here. This is a study that one of the initial studies with the opritinib for patients who are previously untreated, and comparing the opritinib versus chlorambucil. And the results were very impressive, and that was the registration study, the pivotal study that led into the approval of the opritinib as a frontline treatment for patients with untreated CLL. So the chlorambucil became not really the standard of care anymore for this group of patients, Opritinib is, and you can see the separation of the curves here very well. Patients with the IGHV mutation status have also done really well with the opritinib compared to chlorambucil. This is the ECOG study that compared the opritinib with the FCR for patients who are fit for the FCR chemotherapy. So you are talking about patients who are young, less than 70 years of age, with no or very probably low CRS score and no comorbidities. And those patients, obviously, the ones who are treated with the opritinib have done much better than the ones who are treated with the FCR. And that's, I guess, the argument nowadays. Why would you still use the FCR even for the favorable risk patients? It is an argument or a discussion that we have with our patients. Of course, if they have private insurance and they would like to go with the targeted therapy, it's a good option for them for sure. But if they don't, this is a very expensive treatment and many people will not be able to afford it. So they go on the FCR. The side effects of the targeted therapy is basically now we are very, accustomed, to these side effects, and we are able to manage them very well. Cytopenias would be one of them, but atrial fibrillation is a concern. Bleeding is also a concern for the BTKI inhibitors, especially patients who take antiplatelets agents or anticoagulation. Hypertension happens in about 7.4%. Diarrheas also can be troublesome. Most of these side effects happen early on in the treatment in the first 6 months. Once patients, pass the first 6 months, they tend to do well. This is the alliance study that compared the opritinib versus the opritinib and rituximab versus the bendamustine and rituximab. I guess the lesson or the take-home message from this study is the addition of the rituximab did not really add any benefit over the opritinib monotherapy. So opritinib monotherapy became the standard of care. Obviously, any opritinib-based therapy is much better than chemoimmunotherapy. In this case, was the bendamustine and the rituximab. The Captivate study is a study that basically assesses the MRD, but the main thing is you debulk with the opritinib and you compare the opritinib with the opritinib and venetoclax. This is a highly efficacious regimen, but of course, it's not funded yet. It is still under study. It results into deep MRD results. So undetectable MRD is observed in close to 80% of patients. So for the favorable risk patients, for the FCR ineligible patients, targeted therapy is more efficacious. Fixed duration therapy with venetoclax and obinutuzumab is probably preferable, and then the continuous BTKI. Now that we have this regimen funded in BC here. For FCR eligible patients, unfortunately, as I said, it's only FCR that is available in BC, funded through the cancer agency. But certainly it's a discussion that we do have with our patients. And if patients have a private insurance and they are willing to go on or they wanted to go on the another treatment like venetoclax or BTKI, then it would be a good option for them. The major concern about the FCR is the risk of myeloid malignancies, acute myeloid leukemia. The risk is about 5 to 10%, and it has extremely poor outcome. What about relapsed refractory patients? We have at least 3 clinical trials that guide us through what kind of options or treatments are available for the relapsed patients. And the Resonate study, which was the first study that examined targeted therapy against ofatumumab, which was the standard of care for the relapsed patients. And that study showed a significant improvement in the PFS of 44 months compared to 8.1 months for the ofatumumab. The Ascent study was for the acalabrutinib versus bendamustine and rituximab. And this is also showed a significant improvement in the PFS compared to the chemoimmunotherapy. And the Murano study, which is basically the venetoclax and the rituximab versus bendamustine and rituximab. And this has shown a significant improvement of PFS of 53 months with the venetoclax and the rituximab versus 10 months for the bendamustine and the rituximab. The major concern about the BTKI is not the efficacy, of course. We get really good results, good efficacy. And the problem is always, how to manage the side effects and how to ensure that patients stay on the medication. There's an array of side effects that result from the off-target inhibition of the other kinases by the ibrutinib. We have atrial fibrillation that can be quite bothersome, and it can sometimes, necessitate treatment discontinuation or patients needing to be on medications or anticoagulation, which can further complicate the BTKI because it also increases the bleeding risk. And if you start your patients on anticoagulation, in this case, you will need to really be sure that, number one, it's not warfarin. And if it is one of the other anticoagulants, you will need to monitor really very closely and assess their bleeding risk. Infections is one of the other side effects. We don't really see much of the infections. Cytopenias, we are really, as hematologists, we mostly are quite comfortable with cytopenias. We can manage it very well. Arthralgia can be a very inconvenient side effect of the BTKI inhibitors and BTKIs. And it needs, some support, and it usually happens in the first 6 months of treatment. Hypertension, it happens in about 7 to 8% of cases. Monitoring of blood pressure is very important. Diarrhea usually happens in the first 6 months, and it can be bothersome. I have a recent patient who was admitted to the hospital with it, requiring IV fluids, etc. So it can be quite severe, and it can require, some support. Ventricular arrhythmias, luckily, it's very rare. We see some rashes, fatigue, but these are very manageable. So if you can support your patients in the early on, in the first 6 months, and they can stay on the treatment, then it's very likely that they are going to have a very good response, very likely that their disease will be well managed with the BTKI, and they will achieve a deep response. Unfortunately, the BTKIs are not really, they don't result into a high percentage of the MRD. So most of patients will still have detectable MRD if we test for it. Of course, we don't test for it. There is no need to test for it. It doesn't really inform you. It doesn't really change the treatment. But what it tells you, basically, those patients eventually will relapse. And if you stop the BTKI. So what about the acalabrutinib? It is a second generation BTKI, and it has less side effects, compared to ibrutinib. So it is a good medication to consider now. It's funded and available through the cancer agency. It's a good medication to consider when patients have to come off the ibrutinib because of side effects. It has less atrial fibrillation. So with the acalabrutinib, you can see the risk here with the ibrutinib is 16%. That's for all grades, I believe. For the acalabrutinib is 2%. And diarrhea is also much less, not much less, but it's less with the acalabrutinib. Bleeding is probably the same. There isn't really much of a difference in the bleeding risk between the acalabrutinib and the ibrutinib. Arthralgia is much less with the acalabrutinib. So acalabrutinib is basically provides a good alternative to ibrutinib if patients have some side effects and they need to come off the ibrutinib. Zanubrutinib is again, second generation BTKI, and it has much less side effects, compared to ibrutinib. It is not yet approved for use in CLL. I have few patients who went on zanubrutinib for other lymphoproliferative diseases. It looks like it is very well tolerated. Both patients that I have started just recently, they haven't developed any side effects. So it has a very good safety profile compared to ibrutinib. Headaches commonly happen with the acalabrutinib, and typically they respond well to acetaminophen and caffeine, and typically they resolve in 1 to 2 months. So there is no need to rush and discontinue the treatment of the acalabrutinib. Again, into the side effects, acalabrutinib with the atrial fibrillation compared to ibrutinib, it is much less. In some, studies, it shows about 7%. Here, it's 9.4%. So the atrial fibrillation flutter is less with the second generation BTKIs. We can go on with the side effects, but the hypertension is basically, one of the side effects of all BTKIs, less frequent with the acalabrutinib compared to ibrutinib, and bleeding events probably less with the acalabrutinib, but we still see high rates of bleedings with any of the BTKIs. In the Alpine study, which is zanubrutinib versus ibrutinib, it looks like that the zanubrutinib is more efficacious than the ibrutinib, which is, I think, that's good to push the efficacy even higher. But the most important thing with the zanubrutinib, it has less side effects compared to ibrutinib. What about venetoclax? Venetoclax is a different class. It inhibits the BCL2. It causes tumor lysis syndrome, which is a worry for patients with bulky disease with very high lymphocyte count or a bulky lymphadenopathies. It can cause myelosuppression. Some patients need to be admitted to monitor for the tumor lysis syndrome, which is inconvenient thing to do, when you start patients on venetoclax. The resistance to BTKIs is mostly because of this mutation that happens in the BTK enzyme. And that mutation, the C481, is responsible for the majority of the resistance that we see to ibrutinib. There isn't really much that you can do about it right now, but this medication, pirtobrutinib, which is a non-covalent reversible BTK inhibitor, can overcome that mutation and that resistance. So there is a light at the end of the tunnel for patients who develop resistance to ibrutinib. There is a medication that can be effective, and they can carry on with the BTKI inhibitor. Side effects profile is better compared to ibrutinib. So this medication, we watching it closely as it's being developed in clinical trials, but it is a promising medication for patients who cannot stay on the ibrutinib because of resistance. I'm going to skip a few slides here because we've already went through many of them already. So what about, patients who have went through the BTKI, the venetoclax, and they relapsed, and chemoimmunotherapy? So what do we have anything else? CAR-T became perhaps, let me just move to the CAR-T here. CAR-T became a treatment that is used in many hematological malignancies and currently being studied for CLL patients. And CAR-T basically is what you do is you collect the T cells, then you transfect them and manipulate them in the lab, and then you transfuse them back to the patient. So these are basically cells that are being developed to work against the leukemia cells or lymphoma cells specifically. Very effective treatment to provide really, good rates of disease management and potential cure for many patients who have no other options available. Of course, it's a very expensive procedure. It costs around $500,000 to do the CAR-T therapy. We don't have it funded here in BC yet. In other provinces like Ontario and Alberta, they have it funded for some of the hematological malignancies, but it is a promising treatment. We have the Transcend clinical trial for the CAR-T that is still ongoing in CLL, and we are looking for the results of this study. What we are doing here in BC, in terms of the CLL clinical research, we have a provincial CLL database that we participate into it along with the BC Cancer Agency and VGH. We have done multiple retrospective clinical studies, try to answer some of the clinical questions, important clinical questions for patients with CLL undergoing therapy. We have a collaboration with the molecular labs and genetic labs. Real world data have been published, many publications from our institutes here in BC. And we focused on the disease complications such as Richter's transformation, autoimmune complications of CLL, and we are doing research in that regard. Finally, I just want to present a case that is really a very instructive case. This patient was diagnosed with CLL in 2006 at age of 39. 39. He is not my youngest CLL patient to require treatment. My youngest is 32-year-old, required treatment for CLL. But this guy, in 2006, he was 39. And in 2010, he required treatment and received 8 cycles of fludarabine and rituximab. His disease progressed in 2011 and treated with 8 cycles of fludarabine, cyclophosphamide, and rituximab. At that point, the prognosis looked really not good for him. You remember the conversations I had with him at that time. If he did not respond to FCR, then I will not have, other options for him. He went on maintenance rituximab, fearing that, he is not gonna stay in remission, although the maintenance rituximab have never been extensively studied in CLL. It has been studied in follicular lymphoma and other indolent lymphomas, but not in CLL. So we have just, very sketchy data to support the use of maintenance rituximab. But knowing that his disease is really acting poorly, he wanted to go on with the maintenance rituximab, and he paid for it privately. He finished 8 infusions of maintenance rituximab and relapsed in 2014. At that point, he received bendamustine and rituximab with no response. In March 2015, ibrutinib became available through a compassionate access program from Janssen. I grabbed the opportunity, got him on the ibrutinib, went on the ibrutinib and stayed on ibrutinib until January 2019, and that's when he became resistant to ibrutinib. At that point, venetoclax became available, and I was able to access venetoclax through AbbVie pharmaceutical company compassionate access program, and he went on this until January 2022 when his disease started to relapse again. At this point, the CAR-T clinical studies became available at the VGH, so I sent him to my colleague, Dr. Kevin Hay in VGH, to consider CAR-T therapy. He received the CAR-T treatment on the 3rd of May. So it's basically, for him, every time he comes to the end of the road, we get something to keep him going. Very lucky. So that's all what I wanted to say about CLL. Drastically changed in new treatments. Chemoimmunotherapy is becoming, something in the past. Novel therapies are changing the way that we treat this disease. Very efficacious treatments, very well tolerated, very deep responses that we get and very durable. And we were able to overcome many of the poor prognostic markers, and we have many, or at least two good predictive markers that we use nowadays to guide us, which treatment we use. And that's all what I want to say. And if you have any questions, please do.
Yeah, thank you very much, Dr. Ramadan. I think we're just about out of time, but I've just maybe take the opportunity. One question: what are the numbers of patients in British Columbia that we're talking about being treated for CLL? Do we have that information?
I don't really have that information. I can get that information from our provincial CLL database, which is, I would say, it captures a good percentage of patients, but we don't really have all patients in that database. But I guess it will give us probably an approximate number.
Thank you. And for those of you that are with us today, I just wanted to announce next week, the presenter is from Rheumatology, Dr. Daniel Ennis, and he's going to be talking about updates on eosinophilic granulomatosis with polyangiitis. Thank you for attending and have a nice weekend.
Thank you.